Okay, terrific. So welcome everyone. I'm Amy Harris. I'm the manager of the Patient-Centered Primary Care Home Program. And welcome to our webinar today around PCPCH Standard 6A, Meeting Language and Health Literacy Needs. This is a measure that we'll be talking about that will be implemented in January of 2025. This is part of our webinar series, just providing education and some learning opportunities around all different types of measures and standards within the model that will again start in January of 2025. So I'm going to turn it over to my colleagues who are going to tell you more about this measure.
Great, excellent. Thanks, Amy, and good afternoon, everyone. My name's Becky Velasco, and I'm a verification specialist with the Patient-Centered Primary Care Home Program.
And I am Sumit Singh. I'm also a verification specialist with the Patient-Centered Primary Care Home Program, and thank you for joining us for this webinar on PCPCH Standard 6A.
First, just a couple webinar logistics and Zoom etiquette reminders. This webinar is being recorded and will be uploaded to the PCPCH program website. If you're having any technical difficulties, please private message Amy Harris for help. And if you feel comfortable, please have your camera on and put your organization info up. Any questions or comments you have can be put in the chat and we will answer them during the question and answer session at the end of the presentation. You can go ahead and go to the next slide. Can you advance the slide to the agenda slide?
I wonder if Susan's frozen.
Oh, I think Susan did freeze. Okay, you know what? I was just going to go over the agenda, so I'll talk about that verbally. I don't think we need this slide for it while you guys figure it out. Okay. So you can't see it, but the next slide is the agenda for the webinar. I'm going to start by providing a brief overview of the 2025 PCPCH recognition criteria, and then we'll do a deep dive into PCPCH Standard 6A, which is Meeting Language and Health Literacy Needs. Next, we'll share additional PCPCH resources and upcoming learning collaboratives, and last, we'll have some time to take your questions.
I'm gonna see if I can pull it up really quick while we're waiting.
Great.
Give me one.
Paula and Trish are your most experienced, and I feel like they should be able to.
And Susan just texted me to let me know she's having technical difficulties. So let me put it in slideshow mode. Hold on one second, everyone.
Amy, my screen is back.
Yep. I got it, Susan. I'm gonna share it. Yep, no problem. Okay. Okay, and let me just move forward.
We're on slide 4, Amy.
Yep.
Thank you.
Hold on one second. Oh, it's not letting me now advance it from my, hold on. Oh, there we go. Okay, so agenda. Okay.
Agenda, and then great. Yep. So just some background. The Patient-Centered Primary Care Home Program was established in 2009 by the Oregon legislature as part of the state's broader health system transformation strategy to improve access to care, reduce costs for patients, and improve population health. The standards are developed in partnership with an advisory committee and have been revised 5 times since 2009. The 2025 PCPCH standards were developed to support OHA's strategic goal of eliminating health inequities by 2030. The standards specifically help primary care practices build their capacity and processes to address inequities in their patient population. All practices applying or reapplying for PCPCH recognition after January 1st, 2025 must meet these new standards. And for more information, I would really encourage you to watch the recording of the 2025 PCPCH Standards Overview webinar, which is available on our website. So today we're going to review PCPCH Standard 6A. PCPCH Standard 6A is in core attribute 6, which, from the patient's perspective, means recognize that we are the most important part of the care team. Ensuring that patients understand their care is a core component of person and family-centered care. The intent of Standard 6A is to ensure that PCPCHs communicate with diverse patients, families, and caregivers in their primary language or use trained healthcare interpreters. Furthermore, practices can ensure that patients understand and follow linguistically appropriate materials in the languages that patients, families, and caregivers can read at an appropriate health literacy level and in a way that is accessible by individuals with disabilities. Standard 6A is a check all that applies standard. And this means that practices may attest to all measures in the standard they feel they're meeting and earn a maximum of 15 points. This is a change from the current 2020 standards where 6A is a progressive standard worth up to 5 points. You may also have noticed that the title of the slide is the title of the standard is changing from meeting language and cultural needs to meeting language and health literacy needs. Cultural responsiveness has been moved to standard 6E, which is going to be the topic of our webinar on November 15th. So there are 3 measures in standard 6A. The first is measure 6A0. PCPCH offers time of service interpretation to communicate with patients, families, or caregivers in their primary language. This is a must-pass measure worth 0 points. The second measure is 6A1. PCPCH provides written patient materials in languages other than English. This measure is worth 5 points. And the last measure is 6A2. PCPCH assures that patient communications and materials are at an appropriate health literacy level. This measure is worth 10 points.
Thanks, Becky. Now we're going to take a closer look at measure 6A0. Like Becky mentioned, this is a must-pass measure. A practice meets measure 6A0 if it offers free of charge interpretation services to all patients at their practice that speak languages other than English. Interpretation services can be provided on-site or remotely via teleinterpretation. Whichever method of interpretation is used, it should be delivered by a certified medical language interpretation software program or individual. Interpretation services must be available during a patient's entire visit or encounter, and patients may decline the use of interpreters, but they should be informed that interpreters are available free of charge and of the advantages of having a trained healthcare interpreter. Next slide, please. So we'll go over a couple of examples of how 6A0 can be implemented. For the first example, a practice can use real-time telephonic interpreters to communicate with patients in their language of choice throughout their entire office visit and or during telephone encounters. Another example is a practice has bilingual staff to communicate with patients or family members in their language or languages of choice throughout their entire visit and during telephone encounters. The practice has a subscription to a tele-interpretation service as a backup for patients that speak a language outside the scope of the bilingual staff. For documentation, we would require a policy, procedure, or workflow demonstrating how practices provide services to their patient in their primary language. This should include a list of interpreter services used at the practice, things like face-to-face telephonic or bilingual staff, sign language, etc.
So let's go ahead and review the specifications for the second measure in the standard, Measure 6A1. A practice is meeting Measure 6A1 if it provides vital and routinely used documents, printed and/or electronic, in one or more languages other than English. Practices must be able to demonstrate that the languages selected meet one or more of the following criteria. They're the most common languages other than English spoken by the patient population, and/or they're the most common languages other than English spoken within the community that the practice serves. Practices can assess the languages spoken in their community using census data, CCO community health assessments or community health improvement plans, local public health agencies, or other relevant sources. And as you may have observed, this measure has been revised to be more flexible, allowing practices to attest to it who do not serve many patients with a primary language other than English. This measure requires that practices translate their vital and routinely used documents into their top languages. So some examples of vital and routinely used documents include registration forms, new patient paperwork, consent forms, patient education and self-management materials, POLST forms, after visit summaries, screenings for mental health, substance use, or developmental conditions, grievance policy, patient satisfaction surveys, and clinic signage. At a PCPCH site visit, you would need to provide the following pieces of documentation to demonstrate you're meeting Measure 6A1. First, the language utilization report of the practice's patient population. The practice must demonstrate with data the predominant languages, in addition to English, that are spoken by their patients, families, and caregivers. If instead the practice chooses to identify the most common languages spoken in the community, the practice must provide relevant information or data from census, CHIP, CHA, local public health agency, or another relevant source. Practices must also provide examples of their vital and routinely used materials available in common primary care languages.
Now we're going to review Measure 6A2. This is the third and final measure under Standard 6A. A practice is meeting 6A2 if it has taken steps to ensure that commonly used patient material and/or communication methods are at an appropriate health literacy level for its patient population. This is a new measure in the 2025 standards and is based on feedback gathered from patients and community members during the 2021 PCPCH Health Equity Initiative. Participants indicated that patients feel that written medical communications such as registration forms, after visit summary, patient education, and billing statements are difficult to understand. Participants also shared that providers often use medical terminology or use vocabulary that is difficult to understand. Keeping that in mind, this measure was added to the 2025 model. Practices must engage in one of two strategies to ensure that their patients can understand and act on the information they are given regarding their care. The first strategy is review and revisit written communications to improve health literacy and/or train staff in health literacy. Again, practices, can we go back one slide, please? Thank you. Again, practices are only required to implement one of these strategies to meet the measure, although they can choose to implement both. Now we'll take a closer look at the strategies in the following slides. For the first strategy, a practice may choose to review and revise written communications and materials to achieve an appropriate reading level or to improve health literacy. This can be performed by training practice staff or with the help of external consultants or entities. Written communications might include patient education material and self-management tools, preventive services reminders, tests or lab results, care plans, after visit summaries, forms, and handouts. Another example of this is a practice partners with a health literacy consultant to review and update its website. and certain patient communication workflows or technologies for health literacy. The practice also may consider health literacy when leveraging or comparing external sources of written templates and communication tools. Next slide, please. The second strategy for implementing PCPCH Measure 6A2 could be a practice trains staff to engage in frequent real-time communications in health literacy principles or strategies relevant to their patient population. This could include things like directly training staff during onboarding, using internal workshops, or using external resources such as conferences, workshops, online modules, or consultants. So an example of successfully implementing strategy 2 would be a practice training its providers and MAs on health literacy principles, such as reducing jargon, checking for comprehension, and explaining things in a way that consider their patients' health literacy needs. Another example is staff are trained in health literacy assessment strategies, offering patients opportunities to get clarification, leveraging the help of peers, and or making sure that patients are aware of who they can contact if they have additional questions or need materials in another format. At a PCPCH site visit, you would need to provide the following documentation to meet Measure 6A2. Examples of written communications revised for health literacy, or a list of staff roles that have received training in health literacy. We would also need to see examples of written communications that have been revised or evidence of or source of health literacy trainings.
That wraps up our presentation on Standard 6A. The PCPCH program is hosting this webinar series to assist practices and other community partners in understanding the standards. Webinars are scheduled every other Friday through December, and you can find a complete list of the topics and registration information on our website. The next 3 webinars are listed on the slide, and I hope you'll join us, but webinars will be recorded and posted on our website if you can't make it. This final slide is some additional resources you might find helpful. The first is our PCPCH program website. The second is the 2025 TA guide with detailed information about how to implement every measure and the documentation requirements. Next is a link to our TA resources webpage. And finally, the community engagement report and evaluation. Last, you're always welcome to reach out to the PCPCH program with any questions through our program email. Thanks very much.
Great. Thank you so much, Becky and Sumit, and thanks for bearing with us at the beginning with our technical challenges. It never is 100% smooth. So I'm going to go ahead and stop sharing my screen and we'll open it up for questions. Okay. I saw some things pop up in the chat as I was sharing my screen, but I couldn't read those. So let's start with some of the questions in the chat. Okay, so the first question says, can you clarify what appropriate health literacy level is? For example, HealthWise documentation written at a 6th grade comprehension level, is that sufficient?
I can provide some insight around that.
Great, thanks, Rachel.
Yeah, so when we were drafting this standard and consulting with the Standard Advisory Committee and our technical advisory group, what we heard was that there isn't one health literacy criteria that works for every patient population. For example, grade level assessments work for some patients, but then other patient populations, another health literacy principle is more applicable. And so we are flexible on what your criteria is for improving health literacy. And that's why one of the specifications is just that we'd want to understand the source. For example, if you trained your staff in health literacy, where did you get that training? What is the health literacy authority or criteria that you're using? And so we would accept a variety of criteria as long as there's like a legitimate source that it comes from.
Thanks, Rachel. Does anyone want to add anything to that, or?
Rachel, sorry, this is Kylie. I asked the initial question. Just to clarify, is something like health-wise sufficient for, does that meet the threshold for the criteria?
And you mentioned health-wise is written at a 6th grade comprehension level?
Yes.
Then yeah, that would be something that we would consider.
Perfect. Thank you so much.
Great. Thank you for that question. And thanks for the response, Rachel. Okay, let's move on to the other questions in the chat. So when I review legal requirements for providing interpretive services, it is unclear to me what the current law is. It does make me uncomfortable when a family member interprets, for he or she may not adequately be able to address a medical question and can put the patient in harm's way if I misunderstand information. So I think that that is a very common barrier, which is why we do encourage patients to use certified interpreters. However, we also understand that not every patient feels comfortable with that and that they would rather have a family member interpret, which is their choice. But as long as you are making sure that they understand that that service is available and that it's provided free of charge, then it still is up to them if they want a family member to interpret for them. I don't know if other folks have anything to add about that. I don't really hear a question that you're asking, just sort of a comment that makes you feel uncomfortable as a provider, that you might be giving them the wrong information if it's being interpreted incorrectly. So I don't know if any folks on the team have anything to add about that.
I think that might be a good opportunity to, ask questions back or have them explain to you what you just said to them or vice versa, just to make sure that everybody is understanding. I think we have a team member who has a story of, being a young family member trying to translate and being unsure of medical terminology and how to translate that. So it is something that we do hear about, but I think as somebody in the clinic, you could take that opportunity to make sure that you guys are on the same page when it comes to those terms, medical terms.
It looks like Jordan added a helpful note. I work at the same clinic with Randa. Jordan mentions if the family interprets, you could still utilize an interpreter as your representative just in case anything gets lost in translation. Do you folks have any input?
Oops, hold on, the last part of your question cut off. Do we have any input on that? I would say that, yes, that's fine. I mean, if you as a practice want to, have an interpreter come in, I would just make sure that you're doing that in a patient-centered way. If for some reason the patient is definitely uncomfortable with an interpreter for whatever reason, you also want to just be mindful of that and, honor what that patient is asking for as well.
Thank you.
I was in a clinic once and had they talked about a small population of American Sign Language in their community, and in that community they all knew all of the interpreters that were local, and they didn't feel comfortable having a local interpreter come to their medical appointments and know about all their business. So I know there's professionalism and all those things, but that's just an example of where somebody may not be comfortable and kind of flat out refuse an interpreter.
That's a good
Thank
question.
you, folks. Thank you.
Yeah. Okay, so here's another question. For 6A0, could you clarify expectations of direct communication with bilingual staff? Do they need proof of language proficiency? What would the proficiency threshold be? So that's a good question. We encourage practices to use certified interpreters through OHA's certification program. We don't require it in the PCPCH program, but we encourage you to use it or to use those certified interpreters. And the reason is because they are required to demonstrate a certain level of proficiency, and they also are required to know medical terminology. And so while, again, the PCPCH program does not require that, you're very strongly encouraged to do that. And so that would include your bilingual providers. So having your bilingual providers go through the certification process is also something that we would recommend that you do. But again, not required by the PCPCH program, but highly encouraged. So I don't know if any folks have anything else to add to that. Okay. Okay, I agree with the first question about determining. Okay, cool. I agree with the first question about determining what qualifies as okay. We already answered that. Another question about the appropriate health literacy level. Another question about for 6A0, I'm curious about certified medical language interpretation software. On occasion, we find that an interpreter is not available. Do you have examples of a software that we could use as a backup? I'm going to look to the team to that. Certified medical language interpretation software. I don't know if have you guys ever seen that in clinic? On-site visit?
Software, no. I agree with like what Jordan has added to that. We use Linguava, Language Line, Boost, Lingo. So those are the names that we typically hear when we go to site visits of not necessarily a software that they're using, but they're using these folks as a service for interpretation or translation services.
Yeah, I guess I don't know, Charlene, if you want to unmute yourself and it's actually okay if you don't either, but if you want to talk more about what you mean by like certified medical language interpretation software.
Well, I didn't know. I just read it in the thing, and so I was curious about it. We use Linguava and another interpretation service. And so we try to have in-person or phone interpreters. But yeah, sometimes depending on an uncommon language or whatever, sometimes we've run into there is no interpreter, which makes things difficult. And so I didn't know of any software, but I saw that written in the standard. So made me curious if there's some other option.
Let us go back and look at where we have that written in the standard, the certified medical language interpretation software. We might be, let us take a closer look at that. We might be actually referencing what we've already talked about. So like Linguava and Boost, we just might need to be a little more clear on that we're not talking about something like a software program. We're talking about that. But let us go back and take a look at the technical specifications and just make sure that we are communicating that as we intend.
Yeah,
so,
it's that top paragraph on page 141, and it was in one of your slides too.
Great. Okay, perfect. We'll go back and take a look at that and make sure that we're being clear that it's not open for interpretation or no pun intended about that interpretation. That we are just being more clear in what we mean. And I appreciate that question. That's one of the benefits that we as a team that we really get from not only helping you to understand the measures, but also for you to help us understand where we may need some additional clarification around these standards. And that's a really great example. Like I don't think we definitely did not intend that there was like potential software that folks could use. So we want to make sure that we're clear in our language as well. So I really appreciate that question.
And I wonder if we added that because we don't want to hear clinics using Google Translate, which is not a certified interpretation service software. So that might be where that came from or why we put that in there, but yeah.
I think
it just makes it sound like there is a certified software. And
I think it's maybe the software that's like tripping people up or leading to that misunderstanding. So we can definitely take a look at that word. Maybe we use service or something like that just to make it a little more clear. I think it might be the software that's that's causing the confusion. So thanks
Will
for
you
that question.
email clarification out, or how
Yes.
would we learn about that?
Yeah, so actually that's a great question. We're going to be releasing a updated version of the technical assistance guide. So as you can imagine, we've had little questions like this that have come up throughout the whole webinar series. And so we're making sort of small changes and really just clarifications that will come out in December. And then there'll be a complimentary document that goes along with that that explains what those changes are. So just watch for that in December. So that's a good question. And others watch for it too. Okay, so another question. We have a health literacy expert on staff. Does that meet the requirement? That's awesome. I would say, sure, absolutely. If you are having that person take a look at your materials and review, I mean, I think just having the health equity or the health literacy expert on staff does not meet the criteria. But if you're having that person review your materials and think about how you're communicating, then yes, absolutely.
Or even training staff, if they're coaching staff on like whether it's front desk staff or providers, just people that have ongoing communication with patients on how to improve the health literacy level of those communications, then that would be another way.
Yep. That's great. Looks like there's another question about, do we have a list of trainings available for staff for health literacy? When we were developing the specifications for this measure, we did have a list of some trainings that were available. And I don't know if those ended up in the TA guide, Rachel. I don't know if some of them I think are in the TA guide.
There's like 8 listed in there.
Yeah, on page 145, there's a list of trainings. And we'll also be adding just continuously throughout the years, any helpful resources to our online technical assistance library. If you've never been there, basically you just type in a standard and then it pulls up all the different tools or toolkits or templates around that standard that might be helpful.
Yeah, and we have a link to that on the slides, on the last page of the slides. So when you'll all get a copy of the recording and the slides, so you can link to that. Let's see. Looks like somebody has done some training. That's great. Good. Somebody made a comment on Amber's comment about they have some enclaves with, specific ALS interpreters within, or maybe, within Portland as well. Can bilingual providers and staff be certified? Yep, I think we already talked about that. They can go through the certification program. Another comment, we have experienced that Providence Insurance will not pay for interpreters. So the cost falls on our clinic to provide it if needed. So yes, we've heard that sometimes that not all insurance providers will pay for interpreters. So yes, unfortunately, that cost does fall to the clinic to provide it. So I would just encourage you to advocate to Providence, talk to Providence about covering that. We do what we can at the state with our coordinated care organizations, but the commercial insurance is regulated in a different way. So I would really encourage you to just continue to advocate to the insurance companies to cover those services, because they are really important. Okay, so there's another question. This is what it says under the definition section on that page, teleinterpretation. Oh, I see. Okay, this is referencing the medical language interpretation software, which we already talked about. So we'll definitely go back and take a look at that. So thank you for popping that definition in there.
And there may, even if we haven't seen it yet in a site visit, as Kimber kind of mentions in her next comment, I think the reason it's included in the official definition from like CMS and things like that is because there are technologies out there. And so we just want to make sure that we're being flexible if those should arise.
Yeah, that's a good point. And maybe we can just clarify that piece as well. We'll take a closer look at that for sure. Oh, good. Thanks, Laura. So Laura is one of our colleagues at OHA. She works in the Transformation Center and provides support to CCOs on the meaningful language access measure or incentive metric that they have to meet. And so she talks about that. She links to what the reading proficiency for bilingual staff has to be for CCOs. So great. Thank you for that, Laura. Okay, I don't think I missed anything in the chat. I don't know. Oh, hold on. Okay, someone's asking if they can ask about 2A. Yes, in just a minute, for sure. Okay, let's see if there's any other questions that folks have around this particular standard or the measures. And if I don't think I missed any questions in the chat, but if I did, please unmute yourself and maybe ask it or type it again. Oh, okay, go for it, Wendy.
I just wanted to maybe restate my question because I may not have said it correctly. Is there some barrier with OHA not recognizing or not allowing us to use bilingual staff? I think this question got asked to me and I'm just trying to represent it as best I can at the person who's the expert. It couldn't be here. But maybe it's a billing process instead. Does that sound familiar to anybody?
So there are different requirements within different parts of OHA. So to bill for interpreter services under your CCO, the interpreters do have to be certified, or it's certified, or I can't remember what the other, they basically have to be certified in order to bill. For the PCPCH program, we don't require that because sometimes those services aren't billable anyways. But again, we really encourage practices to have their interpreters certified, even if they are bilingual staff. So that might be a little bit where that, confusion is coming in. It's the billing versus what the PCPCH program requirements are. We're a little bit more flexible because we aren't just a Medicaid-based program. All different types of practices participate in the program, not just practices that see CCO members. So we're a little more flexible in that. But again, we would really encourage practices to have their staff certified. So I don't know if that's helpful or if anyone else has anything to add about that. Good. Thank you for that. Thanks for that question. So, any other questions about 6A?
I had one more question. I might have missed it, but for the translating important documents, are there requirements for certifications of like the sources for those document translations similarly as there are for the in-person interpreters?
So for translating the documents, no, we generally don't check. We generally don't check to check who has actually done your translation. So when you're getting the documents translated, we typically don't check to see who's done that. We just want to see that it's been done. So we don't have any certifications around that. So I don't know if our site visit team has ever run into challenges around that. So that's a good question.
Thanks.
Okay. Let's see. Looks like a couple more things popped in. Okay, that's 2A, so we'll get to do that in just a sec. For document translation. Okay,
that was me.
Question. Yeah. Okay. Great. Super great. Okay, and then Laura added something about the Oregon law provides information on healthcare interpreters. Oregon administrative rule requires that on-site and telehealth telecare interpreters be provided by an OHA qualified or certified healthcare interpreter or in language providers who have passed proficiency requirements. So folks can take a look at that OAR as well. So again, you know, it's a little bit different than what the program requires. Okay, any other questions on 6A? Okay, then let's pop up to Jordan's question about 2A. Because, and again, if folks have other questions about different standards or measures, we're happy to answer those at this time too, like we're going to talk about 2A right now. So 2A is the question is the standard where practices are reporting on different benchmarks for different metrics. So it looks like Jordan is having trouble finding a benchmark for cervical cancer screenings. She searched all the links in the TA. Can you point me in the direction of a cervical cancer benchmark?
Yeah.
So I know Rachel just unmuted, so I know Rachel gets this question a lot. So
yeah, so there's a couple options you can choose from. The way that our benchmarks are going to be working for 2A is that you kind of have a list of options instead of just one benchmark that you have to use. It can depend on what source you're using. For the cervical cancer screening specifically, you could use the most recent CCO benchmarks from 2020 and use the CCO specification. So that's one option. And then there's also, if you notice in the TA guide, you're allowed to use benchmarks from other health authorities other than the specific measure stewards, if they make sense for your patient population and you can kind of demonstrate that this is a good benchmark for you guys. So some examples that we've given are the HRSA Health Center Program 2023 benchmarks, as well as the HEDIS 2022 benchmarks. And HEDIS is actually one of the options. But in general, for any of these benchmark questions, if you're ever having trouble just kind of finding benchmarks for a specific measure in 2A, you can always email us and then we can either share some ideas with you or point you in the right direction. Because for some of them, if there's no measure stewards at all that provide the benchmark, we might be able to help brainstorm some other health authorities that do provide a benchmark for that specific measure.
great. Thanks so much, Rachel. As you can hear by how she answered that, she gets this question a lot. Rachel answers our email inbox as well as our phone line. So, and that's been a pretty common question. So thanks, Rachel. So, okay. Well, I don't see
Can
any
I
other.
add just one thing to that?
Yeah,
Like,
yeah.
for documentation for your site visit, it would be very beneficial for you to document which measure steward you're using or where you got that benchmark. So when it comes to the site visit, us as site visitors are also not going through, like you just went through all 8 of those links to find out where you might have came up with that benchmark. So it would be really helpful come site visit time for you to have that information on hand.
Yeah, and that is in the documentation requirements as well for that measure that they have to provide that. So yeah, so good, good. Okay, well, thank you so much, everyone. We're at time, and so if you have any other questions about this standard or others, or how about the application process, anything at all, please reach out to us. We are always here and happy to answer your questions and help provide you with information that you need in order to meet these measures. So have a wonderful weekend, and hopefully we'll see everyone next time at our next webinar. Thanks so much.